the students as well. Okay.
Types who are like, whatever.
The other one is Saki conocido. After having so many times to kill now.
Ladies and gentlemen, as you settle down, please note the emergency exits are illuminated by signs. The exit behind the stage is not in use. In the event of an emergency, please use the nearest available emergency exit. Thank you.
We will be starting in 2 minutes. Please take your seats.
I think you're sitting in my seat. He's asking me to.
Good morning, everyone. It is my honor and pleasure to welcome all of you to the second plenary of HSR 2024. This plenary focuses on advancing inclusion, justice, and belonging in health systems during peace and conflict. My name is Racha Fadlallah, and I am a board member of Health System Global Society. I am also a health policy and systems researcher at the Knowledge to Policy Center at the American University of Beirut in Lebanon. To ground our discussion for today, I would like to start by asking you to reflect on the following questions. So can we please have the questions posted? So I will read them through and please reflect on them. How many of you have been denied health care because of your identity, social status, or financial hardship? How many have been excluded from essential services because of your race, religion, or disability? How many have had to make difficult healthcare choices due to poverty or systemic injustice? How many have struggled to access health care due to being displaced or living in a conflict zone? How many have lost someone because they could not get the care they need or deserved? So while you reflect on this, I would like you to raise your hand if you were able to connect with at least one of the following questions. Please raise your hand. Yes? What about at least 3 of those questions? What about the last question? Can you relate to the last question? So for many of us living in conflict-affected areas, this is the reality for us. This is common. This is every day. This exercise is a powerful reminder that exclusions and injustices prevail in different forms in our health system. And more importantly, it is a reminder that they affect all of us across borders and identities. In time of peace, these inequities persist, but in times of conflict, they worsen. Let us carry the weight of this reality with us as we move forward today. This session is indeed unique because for some of us, being here today present with you means something. As I stand in front of you today, I cannot but think of my colleagues who could not join us. And more importantly, I cannot but think of my country, Lebanon, that is currently facing devastating realities. The ongoing war has claimed the lives of over thousands of people. We have more than 1 million families that have been displaced. This accounts for over 25% of our population. And we have residential areas and familiar streets that have been converted into rubble. And this has happened over the past 6 weeks alone. For those of us in conflict-affected areas, health and healthcare access are constant struggles. Our healthcare facilities are being bombarded. Our healthcare workers are being killed, and patients are being turned away and even dying because they are not getting access to the care that they need and they deserve. So yes, we are witnessing not only the devastation of lives, but also the destruction of our healthcare systems that are designed to heal, protect, and support all of us, especially the most vulnerable. And for me personally, it feels like the international community has remained silent, and if I may add, intentional or selective silence. And for many of us from these countries, even getting here has not been an easy journey. And I'm not only talking about the jet lag, which I'm still suffering from, but I'm talking about realities related to mobility, about having our roads destructed, the airport closed, our embassies shut down, I'm talking about the uncertainties of what's happening next. What would happen if we leave? Will we be able to come back? And certainly, I'm talking about the weight of carrying these realities with us. But being here matters. It matters because today's session is not about shedding light on inequities. We are not standing here to bear witness to those inequities, but we also want to take action. We want to demand justice, equity, and belonging for all of us, particularly those in the most affected conflict and fragile areas and countries. The topic we have chosen for this plenary has indeed grown in its relevance and complexity, particularly over the past 2 years. It has brought many of us to the front lines to recenter care and reform during unpredictable and challenging times. It has also brought us to the brink in terms of taking a stand and standing up for our political positionality and for the health systems that we believe should be represented and protected. And it has certainly brought many, many of us together in solidarity. As we come together today, let us all take a moment and remember. Let us recognize those who could not join us from Lebanon and other countries currently experiencing conflict and wars. Let us also honor those over the past year and in the years preceding who have lost their lives and who have been failed by their health and political systems. Let us also acknowledge the unseen, the unheard, whose pain must be felt and remembered. I now invite you all to stand for a moment of silence. Thank you. Our speakers for today have been invited because of their unique perspectives on peace and conflict, but also because of their shared commitment to justice, inclusion, and belonging. In the interest of time, I will make the introductions brief, but please feel free to read more about our panelists in the app, and you can certainly connect with them throughout the conference. A grateful welcome from the Health System Global to Dr. Seita Akihiro, the Director of Health at the United Nations Relief and Works Agency, also known as UNRWA, for Palestine refugees. Deep thanks also to Professor Paparangi Reid Tumuaki from the Faculty of Medical and Health Sciences at the University of Auckland, who is with us today. We're delighted to welcome Professor Walter Flores, Executive Director of the Center for the Study of Equity and Governance in Health Systems in Guatemala, and Research Professor at the Accountability Research Center in the United States. Our gratitude also to Ms. Rosemary Mburu, the Executive Director of a leading Kenyan civil society organization, Waki Health. As I mentioned earlier, this session has been curated to help us think and feel a bit differently. And I think it seems to be required given the nature of what we want to achieve and intend to achieve through this session. So I'm pleased to welcome Devaki Nambiar, a health system global member and co-curator of this session, along with Steph Top. In addition to her role as a board member, Devaki is also the program director at the George Institute for Global Health. I now invite her to take us on a journey of health system and personal reflection on advancing justice, inclusion, and belonging in health system in times of peace and conflict. Over to you, Devaki. Thank you.
Thank you, Racha, for that moving introduction. In moderating this session, I ask that we begin with some acknowledgements. We must acknowledge the abject tyrannies of war, of political violence, and of forced displacement, particularly as we sit here in the city of Nagasaki, the last site of atomic warfare, which has risen with grace and resolve from violence. We must acknowledge the legacies of intergenerational, patriarchal, systemic dehumanization and humiliation of whole nations, colors, creeds, and gender subgroups, denied even the dignity of self-identification, self-determination, control over land, and control over our own bodies. We must acknowledge the immense suffering that is and has been in the world. As we sit here in relative safety, our fellow world citizens brave, endure, and succumb to suffering. It is, of course, not enough, but still significant to acknowledge and take a moment of silence, as we just did. But we must also speak. Speak to act, speak to power, speak to change. And that is what our inspirational panel of speakers come together for today. We have given them a particularly difficult and different task to convey visually and with words what justice, inclusion, and belonging in times of peace and conflict means, what it means in general, and what it means for health systems. So now I will ask each of them in turn to show and tell their visual and explain their meaning. We will start with Seita-san.
Now?
Yes.
Yes. 5 minutes, right?
Yes.
I count. Yep.
I'll also count.
Ohayou gozaimasu. My name is Seita. I work for Palestine refugees in the UNRWA, and this is a photo I took on the 1st of September in Gaza. That's the first day of the polio campaign, the first round of one. The war in Gaza is harsh. I couldn't express it in my words because it's beyond any expression. I went to Gaza 3 times, and it's getting worse. Today is worse than yesterday, and tomorrow is surely worse than today. It started and lasted, continues from the 7th of October last year. People are killed, people are injured, and the health system is collapsing. And we still have hostages taken by Hamas inside Gaza. So situation is extraordinarily harsh. And all my friends working in the humanitarian assistance said that they have never seen this humanitarian crisis in their entire life. And it continues. UNRWA, we serve for the Palestine refugees and now entire Palestinians in Gaza. We lost 243 staff killed, including 12 health workers, which I know. One of them were killed the day after I met him in Gaza with the entire family of him. And also health workers, as you mentioned. More than 1,100 health workers killed in Gaza. This is totally not acceptable. So if you go to Gaza, what you see is tents, garbages, sewage water everywhere. Nothing is functioning. We are massively failing international community. And the polio happens because no sewage system, no lower vaccination coverage, and the vaccine-derived polio virus became, type 2 became rampant. We had one case after 25 years. So this is the photo. For me, this is a photo to show the hope and the importance of peace. Why? On the day of the polio campaign, I went to this Nuseirat camp, which is Nuseirat Health Center, which is middle of the Gaza. I saw the more than 100 meters of queue of the people, parents bringing a child, waiting for the polio vaccines. And this is truly the hope. They really want to give a vaccine to the children. At the same time, our staff work very closely with all the partners, thanks to WHO, UNICEF, and the Ministry of Health, organized a campaign. So it was quite a good campaign, covering almost 96% over the 560,000 children less than 10 years old from the beginning. So that is a very good outcome. And you could see, why I say this is hope. You could see this girl is very well dressed, right? Very nicely dressed. And when I went to the health center waiting for the kids to come for vaccines, I found many of them are very well dressed. Then I asked them why. They told me, this is their first time since the start of the war, the family can go out without any fear of the bombardment. It broke my heart. So that's the entire reality. So we are very pleased that we could give this kind of a tranquility to the people, and also that this could show our joint effort to address the health needs of the people in an extraordinarily difficult time. In the health workers and also us in the United Nations in Gaza, we've been harassed, we've been humiliated, and we've been bullied to the other conflicting parties and also the others. But this photo tells us that we never give up, we never stop working, we continue our fight against the diseases in the way we could do. Polio campaign is not the most important health interventions, to be honest. But still, this is the most important our joint work to prove that we never give up. But this is also the sad photo. During the campaign, bombing continues. During the campaign, people killed. And after the campaign, we went back to the war. And the situation in Gaza became rampant. And so this photo is a reminder, this is what we could achieve, and this is what we could maintain, but also this is our future. We are obliged, we are accountable to continue this photo in all the parts of the world where under the conflict. Thank you very much. 5 minutes sharp.
Thank you, Seita-san. Thank you for that. I might be the wrong person to be moderating. Anyway, we'll now invite Paparangi to talk about this visual.
I'd like to start by an acknowledgement. Kia tau te maunga rongo ki rungu I te whenua he whakaro pai ki ngā tāngata katoa. May peace be widespread over the land, and may there be good thoughts amongst all people. I'd also like to acknowledge this place as a place of peace and hope that we will all be infected by that. I chose the letter C because there's so many words that begin with the letter C that I think are important for us. And one of the ones in the title of the talk is conflict. And sometimes conflict is interpreted as war. I think it means violence, but it means all sorts of violence, not just bullets, even though I accept the critical importance of your talk. For Indigenous peoples, the C stands for colonisation, and we have a deeply relational engagement with colonisation. And I want to dig into a little bit of history. The other C words associated with colonisation include Christianity, because colonisation started with the papal bulls, and claims, the claims from the doctrine of discovery, the claims that Christian people had over our lands, over our peoples, over our resources. It also infected science and started with the classification of humans, some being of a higher order than others, and that allowed the enslaving of people and the dehumanizing of people. Another C associated with colonization is confiscation of resources and the creation of new lands, i.e. discovery. Australia was discovered despite hundreds and thousands of people already living there. New Zealand was claimed, the South Island was claimed by discovery. So this is a myth, a fiction, a creation of colonization as part of imperialism. And it's spread amongst us as capitalism, as consumerism, as commercialization. And we saw the worst of this amongst us in our health systems with COVID, where some people got access to vaccines and others didn't, because despite the best scientific brains working collectively on it, it became commercialized. It's also playing out in our climate, our greatest threat at the moment. And I want to say, when we're thinking about how does this impact on health systems are currently designed to deliver unjust, inequitable outcomes. We want the health systems we work in to have different outcomes, to have just outcomes, to have equitable outcomes, to include people, hence the name of this session. And we often think maybe with a few tweaks we could make our health system better, but I worry that maybe we can't, that the health systems around the world are delivering exactly as they're designed, and while we may tweak it, we may not fundamentally change it. The health system is designed to manufacture and continue privilege. It reflects the values of the society that it works for. And our question is, can we change the system? We hope for incremental change, or do we need radical change? Or do we, I propose, have to change our values and redesign a system that really reflects our social values? Because the systems we have at the moment, if they're reflecting our societal values need to change to become more human. So I hope that's not too much of a Debbie Downer to end on, but I really think we need to look at our values, not just our systems. Tēnā koutou katoa.
Thank you, Paparangi. So, C also for change, in terms of change in how we think. I'll now hand over to Walter to explain this visual.
My graphic is intended to help me explain what I have learned about conflict and peace over the years. For the lower axis, as you can say, I have the years. I could start the graphic in the year 1524, which is the year of the European invasion to the Mesoamerican region. And there are plenty of historical accounts to identify different episodes of peace and conflict during this long period to the present, particularly episodes related to forced labor of indigenous communities to produce goods for the international markets. For instance, indigo, coffee, and sugar. And more recently, episodes of oppression and dispossession of indigenous lands to produce palm oil and mining. I can also include more contemporary episodes, such as 36 years of civil war, for which the True Commission documented that over 90% of all the crimes during the war were committed against indigenous population. This would be a very long and very busy graphic. Instead of the historical graphic, I can start about 35 years ago. That's when I was an undergraduate student in psychology, and I was supporting community-based mental health work. And a few years later, I was supporting training programs for rural indigenous communities about how to run their own vaccination programs, since healthcare workers were not reaching them due to distance, and also because they were in territories affected by armed conflict. Then I can continue identifying and plotting many episodes of peace and conflict in those communities I have worked for over 35 years. But because of time, instead of talking about specific episodes of peace and conflict, I would instead like to reflect about and challenge those same notions of who decides what is conflict and peace for whom. In my view, conflict is about violence, and frequently this violence is against individuals and communities that are oppressed and discriminated because of their ethnicity, the gender, sexual orientation, religion, and others. Violence is usually exercised by state actors, but there is also violence due to inter-ethnic conflict and violence exercised by transnational corporations and extractive industries in their goal to enrich themselves and satisfy the global markets. Returning to my question of who decides what is conflict and peace for whom, my graph has those two dotted lines that you can see there. At the bottom, there is the low-intensity conflict. By that, I am referring to the conflict and violence that may occur in specific territories and experienced by specific populations that do not reach the definition of conflict, therefore not attracted international attention. Despite this, these populations are living through conflict. They are experiencing violence. And it may be physical violence, but also it is violence caused by unnecessary exposure to infectious diseases, violence due to food insecurity, violence due to lack of clean water. The dotted line at the top, I'm calling it assigned peace. And I mean by that when marginalized communities, despite experiencing different forms of violence, are told by national and international actors that they are in peace, that they are living peaceful time, that elites, being the warring elites, being economic or political elites, have assigned them peace. Obviously, none of these communities are consulted about what they understand as peace, what they expect from peace, neither how they are experiencing conflict, how it is affecting them or not. In summary, instead of absolute categories of peace and conflict, for me, those are relative categories. And these relative categories are an expression of unequal and unfair power relations.
Thanks, Walter. Thank you for reminding us about the power of defining even what these categories are. I'll hand over now to Rosemary.
Yeah, so thank you so much. My graphic is a graphic by Juliet Young, a creative clinical psychologist. I think many of us have seen this graphic on social media, and it really depicts the question around, is it that certain populations are hard to reach, or is it that certain services are hard to reach? And it challenges the way we categorize different groups, different populations, and how we put them into buckets and determine that they are actually hard to reach, as opposed to interrogating the health system and thinking about where the barriers are and addressing those barriers. In thinking about this graphic and this question we are dealing with today in terms of advancing health system equity, inclusion, and belonging, I didn't exactly focus it on peace or conflict, but I was thinking about more general in terms of equity, in terms of inclusion, in terms of belonging. And it raised 4 questions for me, which is what I want to reflect with you. One is the concept around people-centered health systems. Looking at this graphic, which is a true reflection of what is happening in countries. Is it really feasible? Is it within reach? Or is it just rhetoric that we can actually work towards people-centered health systems? The other thing is that there are many people who are being missed by health systems. And I think the question is, do we know which people those are, which groupings of people those are that are being missed by health systems? I know we have many different clusters of people, including indigenous people, women, refugees, internally displaced persons, and so on and so forth. Many, minorities, gender minorities, people of color, aging populations, etc. But I also wanted to highlight a particular group of people. The exclusion of pregnant and lactating people from research. And I'm saying that because of the intersectionality between clinical research and access to medical products and technologies. And so for this particular group of people who are breastfeeding and lactating is a clear example of how policies and how research, including clinical research, excludes certain people. And with this, you find that this kind of exclusion leads to a lack of data on dosing and maternal and fetal safety, limitations around prescribing, potentially beneficial interventions, exclusion from potential direct benefits of research participation, and so on and so forth. And it's just one example of a particular group of people, a particular population that is left behind and denies us the opportunity to actually translate and think about solutions, like policy-oriented solutions, because of the missing data and the missing evidence. I think in terms of health systems and their role around being a redress or helping to mediate when challenges or crises or conflicts arise, we find that health systems themselves also contribute to deepening the social inequity. In which ways? For example, by failing to protect, to offer or provide sufficient financial protection against high out-of-pocket expenditure. And this is not just in low and middle income countries. We know around the world where healthcare is actually not affordable. We do know from the Global Monitoring Report that about 4.5 billion people around the world do not have access to essential health services. Over 2 billion people around the world actually suffer financial hardship in accessing those services. And this pushes more people into poverty. And so the domino effect around that is that you have more difficult livelihoods. People cannot access schools, people cannot access jobs, people cannot have financial inclusion, and it just goes on and on. I think the other thing to mention is the failure of health systems to strengthen community health systems. One of the things we saw when we just came out of the pandemic is that even though there was a reversal of gains that had been realized over years, we saw countries and communities where resilience was documented, where there was evidence of resilience. And one of the things that was different in communities and countries that showed resilience are countries where funding partners, international funding partners, came together with national governments and community-led programs, robust community-led programs. And it argues that when you put community leadership at the center, when you prioritize community system strengthening, it contributes to strengthening health systems. It contributes to reaching the last mile. It contributes to reaching communities like depicted on this photo who are actually not being reached by the services. And the last thing is to mention that I also think that the other failure of health systems that leads to the kind of situation we see in this photo is the failure to respect, protect, and fulfill the human right to health, or the right to health. I think, there is a disconnect, between health systems and human rights framings and approaches. The intention is that health is a right, but more and more, the fact that we have many people being excluded because of their social status, financial hardship, and so on and so forth, is a true reflection of the disconnect. And I think it's really important to think about health systems and think about provision of services from a human rights-based approach. There is evidence showing that that can lead to improved health outcomes. And so thinking about gender transformative outcomes, integrated services, accountable services, and really upholding the human rights principles and values of non-discrimination and equality, participation and accountability. And the last thing, Devaki, is to say that many people might have seen the People's Voice survey that came out last year in December. And it was a survey that looked at 25,000 people, and it was asking people, how confident are you in your health system? And the general and summary of that survey and report is that a majority of people said that they are not, they don't have confidence in their health systems. And it didn't matter whether you are from a low and middle income country or from a high income country or from a country that has health insurance. Generally, health systems around the world are failing. And so I think it's a call to action to really think about, is it missing data? Is it missing evidence? Is it political will? Is it the resources? Or how do we actually ensure that everyone everywhere can access health services without suffering financial risk? Thank you.
Thank you, Rosemary. So now you've thrown down the gauntlet with a call to action. So let us start to think about our own positionality. When you entered the room, there was a Slido about your own profession. And we asked our panelists a similar question with an added twist. We said, in your profession, in your positionality, what is it that you can do to be a just actor in this space, given the context and your understanding of building justice, inclusion, and belonging? So now we will turn over to the set of images we got for that question. And the first person speaking will be Rosemary again.
Yeah, so when we came into the room, the question was, what is your profession? And a lot of the people in the room are researchers, public health practitioners, and so on. And I was trying to look, like, how many of us are advocates? And I think there was one advocate, a very small, tiny. But I think for me, the point is that we are all advocates. And in the places where we work, we have the data, we have the evidence, we have real-time information of what is wrong with health systems and how we can bring solutions. And so mine is to really call upon everyone to really advocate, to speak up, to be the voice in terms of ensuring that we can support health for all. And really thinking about, when we think about universal health coverage and how health systems can really help us to get closer to that or make progress to that, to really think about the you in the universal, meaning that it's everyone, everywhere. And so that's really my call to action. We must protect everyone, and I think we really need to be louder, stronger, and make some good trouble sometimes.
Good trouble, thank you.
Yeah.
All right. We'll hand over now to Walter to explain his positionality in this.
Great. In these photos, I'm sharing with some of the staff of the Action Research Organization that I'm part of. It's the Center for the Study of Equity and Governance in Health System, and some of the actives of the network of community health defenders. In the year 2006, after working in academia in the UK and also with international cooperation agencies in the US, I felt that I wasn't doing very much in terms of tackling the structural issues that was excluded marginalized population. So I returned to my home country, Guatemala, and I founded this organization with the support of a few students. And some of those students are here now, very accomplished professionals. They're here in the audience, 3 of them. And by the way, I'm not the executive director anymore. I transferred the organization to 2 of them. There are here 2 female indigenous leaders 5 years ago. So it was 5 years ago. I'm just an advisor now, doing some research, but they run the organization. I'm very proud about that. So from the beginning, the idea was to do bottom-up work to try to tackle structural issues of discrimination, racism in health. And the idea was work together with community activists. We started with 5 activists, a few communities. Now we have 120 activists, 31 communities. And the work that we do with them, this specific photo, is about a learning exchange last year on strategies to support individuals and communities for restitution of the rights. For instance, accompaniment and paralegal support for cases of denial of birth registration just because the child was born at home. It wasn't delivered at hospital. In rural areas, communities are denied the certification because they did it at home. Also, they support cases of no services provision because of discrimination just by being indigenous or being poor, or demanding bribes. They didn't pay a bribe, they did not receive the service. In other words, different forms of violence that have denied their rights. Also, through different cycles of participatory action research, the community defenders and ourselves have co-developed and learned about participatory capacity building approaches, community mobilization and advocacy at different levels of the system, and also expanding into other rights. There are strategies that have been effective for health. They are expanding into education, into food security, into resilience for climate change. Also, with these activities, our view is the community defenders contributes to the checks and balances and also to the democratic governance of the Guatemalan system and overall public health services. But for many years, the work of the community defenders was on rights literacy and rights claiming and demanding responsiveness from authorities. As you can imagine, this kind of work can create tension. It's an adversarial work. Sometimes there are backlash, threats, and all of that. But because they have done this for years and they have developed profound knowledge about the structural barriers and challenges, they are now recognized by their own authorities about the role that they play to improve the systems. In recent years, these tense and adversarial relations have evolved into a more strategic engagement with duty bearers. For instance, community defenders are now working with frontline healthcare workers and local authorities to try to tackle the causes of structural discrimination and aiming for the shifting from a rights violator system to a health system of inclusion that listens to communities, that contributes to peace.
Thanks. So what you're talking about, moving with communities across generations, across issues, building that confidence over time. Paparangi, this is your image.
This is a photo of my daughter when she was at secondary school, engaged in a haka, and putting aside the local context of what's happening in Aotearoa, New Zealand at the moment, about the haka and about the role of women. It's also a quote there from Donna Awatiri from last century, actually, when she said, "I dream of a time when it's safe to be born a Māori child." Like many in the room, I'm an academic and I am a health activist, and also believe or hope to be an agent of change where we get change in terms of health outcomes for our people. But when I became a mother, I became a very, very dangerous woman. And actually, it just came, yeah, you know, you might know what I mean. And then I had to really think about it. What does it mean when I feel like that about my own children? And how do I make sure that I feel like that about all the children of the world and all of the people, all Indigenous peoples? And so I want to really put up this photo as a photo of how we must continually think about not just our own personal family circumstances, but how we must fight for what's equitable and what's right in the world. And we must fight. I'd hate to quote Donald Trump at this moment, but it is actually probably the only time I'll ever quote Donald Trump. But there's a lot of work we have to do in this space. Kia ora.
Thank you, Dangerous Woman. think many of us can relate to the ha. So now we'll hear from Seito-san with this image.
Yeah, 3 minutes. Nope.
Yes, sir.
Let me try. So this is a photo I took in the Gaza City in April 8th. My first time went to Gaza City from the south after checkpoints. And this is the asthma asthma school, the first health point we opened in Gaza City. I was so privileged to visit there. And of course, because of security reasons, we have to put the helmet and the vest. It's heavy and tough. But these people never left Gaza City from the beginning of the war. And then when they opened the clinic, they walk 1 hour, sometimes 2 hours, they told me, to come to the clinic or medical point to provide the services to the people there. And so they're very proud people, and I really appreciate this. I went there in July, and I met the same people, and then they told me that they have never seen vegetables and the fruits last 2 months. And so that I was lucky to go 2 days later, so I bought quickly the fruits and the vegetables, brought to them to give to them. This is, I don't know, this is something I could do, good or bad, I don't know, but this is how. And this is the place I'm here, and this is the place we should be there. Because this is everything of the health systems to me. And then for me, my bare minimum now, to respond to your question, is to maintain our services. If we maintain the services, that is more than what we could do. And if we can expand this with the help of the partners, partnership is extraordinarily important. And with the help of the community, if we can do more, that's also great. But nevertheless, people like this will tell me that we should never give up. They lost their houses, all of them migrated, internally displaced. And then many of them lost their families or relatives, but they still come and work. And at that day, one egg cost $3, but they come and work. So we should continue to work with them. And then the energy of this is the respect to them, but the anger. So we never accept the inequality, injustice posed to them, anger. But I'm a Japanese, so I don't shout. I don't show emotion. As also bureaucrats, so I don't show emotion. But nevertheless, this translating anger into energy to continue to provide the services, and so that we show that we never give up. We continue the services. And then that's what we need to do. Yeah, thank you. Less than 3 minutes. Thank you.
Thank you, Seita-san. It's time now to hear from all of you. So we'll put up a Slido, I think. And I'll just ask, so please, at some point, yes, we'll be putting up the Slido link. And we'd like you to raise any questions that you have for the panelists. As you do this, I'm going to start with some questions. But one thing, as you've heard from everyone, we've worked hard to make this a safe and honest space, and request you all to keep holding that safety for us in your contributions. I'm going to just start us off with some questions, but if you have burning ones, please send them in. We'll put them up gradually and try our best to answer them. So the first question for anybody here to answer is just getting right back to it. What should researchers be doing? Coming back to the central question, what is the relevance of what we've been discussing, this anger, being dangerous, making trouble, passing on legacies generation to generation? But for those here, what should we be doing in health policy and systems research? Would anybody like to take that on as researchers?
Professor?
Yeah, what I have learned through this work with the community have told me that is that because we work in health, we try to have the idea that this is a benevolent service, that we're always doing good, and we do not realize that in all low and middle income countries, the health systems are a reflection of colonial and neo-colonial structures. And they still replicate that. So a lot of the exclusion inequities is not because of lack of evidence or lack of knowledge, it's because the structures were meant to exclude people. So I would say the health system research one of the things you should do is to be more self-critical about not to start with this idea that it may be just a technical solution, it may be just a financial solution. Understand where we are working with structures that come from these very inequitable oppressive periods, and some of those features are still very present.
Yes.
So we need to understand those structures in this historical perspective so we can engage in a better way in trying to find solutions for the structures.
Thank you for that. You raising this point of studying and questioning the structures, not taking them as given, because as you said and Paparangi also mentioned, they may be working as designed, right? And that's the problem. So understanding the nature of that. Any others wanting to take this question?
Please go ahead.
I'd like to quote Linda Tuhiwai Smith, who said the research we need at the moment is research that saves the planet, that rebuilds the human spirit, and locates lost humanity. And I think that's a good starting point. I know we're all also trying to discover new something or others, etc., but fundamentally, the human spirit and our planet needs healing.
Yeah. And I think the something or others will come if we follow these. Right. Yeah.
So I want to remain positive, but we suffered a lot and we are suffering a lot. Mm-hmm. And then telling the world that how the Palestinians are suffering, you can see the news and everything, and then that we try to give evidence and numbers. But what I learned in this conflict, even nowadays in the world, is my number is not your number, my evidence is not your evidence, and your evidence is not my evidence. There's a huge, so not the conflict, but a huge difference in the opinions to interpret the numbers and evidence. And I think that's the important part the researcher could help. Mm-hmm. We have a very good researcher who forecasted the deaths and the burden of disease, deaths in the Gaza. We have an IPC recently published, and for the famine, risk of famine. I think what is important for researchers is to give the clear number that the degree of suffering and also predict the future of the suffering in a scientific way. And after that, the people like us think how we can sell to the world. And then in the current very complicated world. Yeah. So researchers are always welcome.
Researchers welcome, thank you. All right, we had a question here about the role of finance, but then there are a lot of institutions. At the institutional level, are there any reflections from the group here on what could be done to make health systems more just, inclusive, and foster belonging? And then we'll turn to these.
Yeah, I can take try on that one. So I think in terms of the role of financiers, funding partners, I think one of the things to put in mind is that so we need to invest in health systems and in all the ingredients. Like we know the solutions, we have the evidence and all that. But I think we also have to look at the other factors, the enablers, the things that limit and undermine the optimal, functioning of health systems. For example, when you think about laws and policies, I think those especially, that's an area where I think we can see more investment and more support, because a lot of the people who are closed out of health systems are either criminalized or really the laws and the policies are a barrier to them. So thinking about how to remove legal barriers would be one way to invest in ensuring that people can actually access health service. So I think it's looking at the entire ecosystem and not just thinking about investing in capacity for health systems and all. And all those things are really important and they need to be done. But I think it's also thinking about what are the other important things that are not funded, that are enablers or determinants for success of health systems.
Right. So thanks, Rosemary. Thinking transdisciplinarily about these legal frameworks and the neglected issues as well, and populations, as you raised earlier, being vigilant to that. So, gosh, there's a lot more questions than I thought there'd be. But I think there's one that intersects with a lot of others that has to do with the war in the Middle East and the role of health policy and systems research. Would you like to venture a response to that?
You're talking me, right?
Yes.
Yeah, to advocate for the coup.
What can we do to advocate as health policy and systems researchers?
I think this answer to this question related to the above two questions.
Yeah.
How to raise our voices together under the current complex world. In this current conflict, both parties of the war and the one big party supporting the other party don't listen to the rest of the world. And it never stops, it continues to work, continue to listen. So I think what we need to do is that we continue to raise our voices and continue to explore all the possibilities. Let's say, for example, UNRWA are on the brink of a collapse because of the two bills against UNRWA is in the past Israel Knesset parliament. And then by end of January, it could be implemented. If it's implemented, we have no legal ground to operate in UNRWA in territory of Israel, probably including the West Bank and Gaza. So what we do, we explore all the possibilities. We go to all the government, and they are trying to go to the ICJ. They are trying to make a legal case inside Israel. We just never give up. Say, for example, UNRWA, we have no plan B. People ask me, what is your contingency plan? We have no plan B. We are important. We are doing United Nations ask us to do as a mandate. Then why the hell we should give up? If somebody else tell us to, but it's not the one member state tell that the General Assembly decided so to do something against General Assembly decision. So I think we never give up. I think it's important for us to never give up, continue to raise the voice, and they give us the evidence so that we will continue. Thank you.
Thank you for that missive of never giving up. A question again to all of you, and there were some questions also about what's happening in specific countries. But given this fractured scenario we have, how do we build solidarities across countries, across communities, across lines and divisions? As researchers, how can we move forward with that? Thoughts on that? That's a hard one. Do you want to give it a shot? So we have this question about global action in a fractured world. So the fact that we are sort of divided.
I cannot see it.
Oh. It says, we know what the problems are. How do we harness global action in a fractured world?
Yeah, right. Well, if I answer that, I want to connect it with another question that I saw is about how to embrace politics within health systems.
Yes.
They are very much interrelated because health systems are political by nature. And also, when we say that no, we don't want to take a political position and we're only objective researchers, that's already a political position. So I think that we should be totally open that these are political positions. As there is no problem, you have to have a side saying how you're going to change the politics, because our goal, if we are for equity, for inclusion, well, we have to fight this structure that occurs there. So that means political positions. It means that our research, our evidence, our work contributes for somebody that is fighting or is challenging those structures. But that's already taking political stances, that you're producing knowledge and evidence for oppressed population, for marginalized groups. So that's already a political position. So I think that we should be more open about, it's good doing that. It's important because working across all these systems affect the country will require solidarity, more solidarity, enhanced solidarity, and also dignity for all. There's some recent efforts in international development trying to measure dignity as an outcome of development. I think this is great. We should move into that direction. We should value whether our actions in development in health system research is contributed to dignity for more people, and also how are we contributing to have more solidarity, because these two values are the ones that can really help to challenge these very strong structures that maintain the situation of exclusions, of inequities in many of our systems around the world.
Mm-hmm. Thanks. There are exemplars of taking this accountability and using the politics and moving them forward. We have many questions actually about the transformation in New Zealand, Paparangi, in Aotearoa, New Zealand. Could you talk us through how some of those shifts have happened in positive directions and what the challenges may have been in holding governments accountable?
I'd like to start by acknowledging that sometimes those transitions are not permanent and the tide goes in and the tide goes out, and sometimes we have to flow with the tide a bit, allow it to go in and out. The politics of change happen, but how do we keep as much of the gains as we can? I think there was another, just to change it a little bit, there was another question that talked about can we alter, health systems become liberatory if we get rid of our roots in the sort of colonial system. I think that we can, and that there's many examples around the Indigenous world of health systems that are by the people, for the people, and with the people. And the biggest challenge to them is the commercial determinants of health and how that interacts and often fails and undermines and erodes that people power. So I think economic stability for those groups is really important. With the change in New Zealand, in Aotearoa, New Zealand, to a right-leaning, severely right-leaning government, we have seen the undoing through legislation of Māori, of Indigenous actors, of Indigenous services. So that's what I mean. We have to be ready for when the tide goes out and what can we hold on to, and so that when the tide turns again, we can build again. But it's a very precarious position. Right. And the other thing I'd like to say that has happened is that we are part of a demographic change. And we are now 20% of the population, 19% of the population. We are a young population, and I think managing our young population going forward and taking over the world in a population way, I think that's part of our solution.
All right, great ambitions there, thank you. There was a question here about different types of internecine, internal conflicts. You can see it's at the bottom there. Wars are discussed often. Internal conflicts within countries have much larger and sustained impacts. And Paparangi, you were talking about turning the tide there, but also realizing it's a tide, right? I wondered if others wanted to talk about these internal sort of conflicts and dissonances and how one addresses those from a health systems perspective.
No, I think I would like to comment again on, not to ignore that, but I think someone has more expertise in terms of conflict settings. To comment back, one, on what funders can do, what financiers can do. And I think one point that is important is that we see how at country level, especially like LMIC countries or countries that especially rely on external funding, how there is fragmentation of that kind of support of the programs that come to the country level. And there is evidence that if there was more coordination and more synergies in how the investments were done and aligned to the national strategic plans, national health systems plans, and all that, would be more impactful. I think that's something to remember. There is always the conversation of how do you invest so that the investment does not just benefit disease outcomes, but also health systems outcomes. So I think that's something to think about. And the other thing is about accountability. I think taking it a little further is to say that when it comes to accountability and involving people, making people part of the process and part of the system, it's important to think about social accountability and social participation. We do have guidelines now from WHO, which countries can actually contextualize, that have been co-created, even with civil society, with countries, to give us a guidance on how we can be better at social participation and really provides how does meaningful inclusion, how does meaningful engagement look like. And I think it's important that there is that room for contextualization because engagement looks different from different countries based on, I think, the different groupings of people there are, laws and strategies. So I think that's something to think about. How do we, and I think this works more for stable democracies. I don't want to undermine how difficult it might be in a conflict setting, but I think for stable democracies, it's important to think about the people as part of the agenda setting process, as part of the accountability framework, and really as really at the center of everything that we are doing within the health system. Yeah.
Walter.
Yes, I want to answer the question of the internal conflict.
Yes.
And for that, I will go back to my graphic with the idea that it's a relative concept.
Yes.
And because some area within a country has been assigned as a peaceful area, some may think that if population do not come to the facilities, do not bring the children to vaccination care, it's population that are being ignorant. They need education about the importance of vaccination, the importance of continued care, without realizing that these are populations that are in settings of low intensity conflict.
Right.
The ministers of health being expressions of government, for them is re-victimization of violence. So I think universities, places that train researchers also about issues of health policy and research, we should pay attention about, before jumping into classifying and saying, oh, they are ignorant, do not know about the importance of vaccination, trying to understand what is going behind those communities, what is the longer issues of conflict and violence that may be affecting how they perceive anything that comes from government, anything that comes from these institutions that have excised violence on them. So these issues of violence and conflict, to me, are very extremely important for health policy and system researchers, and it should be something that we should be aware all the time and asking and reflecting about it. Okay, is it possible there's something behind, something that goes back in history that may be affecting how these communities are also perceiving the healthcare providers and overall health system.
Thank you for that. And I think what you're saying has also to do with giving the power to communities to really define the terms of what's important in health systems and what should be prioritized even for research. One more question. I'm just riffing off what you've said. There's way too much happening here, sorry. But what have been your experiences of trying to work meaningfully with people from communities, including in conflict settings, to bring them to the table? It's not always straightforward. It's not always the right time. We spoke about tides. Could you reflect a little bit on your experiences trying to give power to communities to define the term, to define health systems, what's important in health systems?
So maybe I start. I don't want to sort of dominate discussion in the situation of Gaza, but it's important to remind ourselves that what's happening in Gaza should never happen in any part of the world. This is a total accumulation of the inequality and the injustice. And so to address such this, say, if you imagine it happens in your country, if you leave anyone behind in the way that the entire world left Gaza behind, it should not be acceptable. And that's the important part to respond to your questions. I think we start from them, we respond to their needs, and the polio is a wonderful example that people want the vaccinations. The mother told me when I went to the campaign that in Gaza, I understood the people call them as a disease of paralysis, and then they understand the vaccine works. So mother told me that it is my duty to protect my daughter from the disease of paralysis, and that's the reason I brought my daughter. The other mother told me that this is, we are under the war, so we have a hepatitis A, we have a diarrhea, all the diseases. But this disease of paralysis, vaccine help. So I brought my daughter. I think that people's needs, we need to respond to them, and we modify to this. In case of Gaza, that we are discussing already recovery in the time that nothing never ends. But I think important part is that once the ceasefire happens, which is the most important part, that I don't think Gaza will become to the pre-war Gaza. And then so how we respond to the people's needs and movement and establish a system in the way that changing Gaza, it's also an important part of the. Sorry, I just want to utilize the time. The people, there's a question that this fragmented world.
Yes.
I don't think we are fragmented, particularly in this room. I don't think anyone is fragmented. We share the same value, we share the same concern, we share the same empathy to the people who are suffering the most. I think that's a fundamental value for any public health work and the research. And I think that's also the part. And how to raise the voice, just continue to raise the voice. And this I like the famous word genocide, we don't use it. We simply do not use it with the different reasons. Nevertheless, there are so many ways to express the suffering of the people in Gaza, in the research, in the narrative, in many different ways. So I think we are not fragmented, we are united, and then we need to address the people's needs collectively and scientifically. Thanks.
Thank you. Any other reflections on involving communities, Walter?
Yes, it's something that we have learned together with the community defenders, the activists, is that we have this idea that in health system to improve it, we all want to work at the national level. We want to influence the national level. If we influence the national level, then everything will improve. But that doesn't really work in that way because health systems are about resources and relationships. When you move to the central level, the relationship get lost. Yeah. Everybody just numbers there. So it's very difficult to work at central level because it's only number relationship. But at the municipal level, local level, relationship is very strong in the resources. So you can build reform, you can build movement by strengthening these different levels of resources and relationship, and then having enough leverage, enough coalition of power to influence and to make the national level that relationships are also important. And also, if you were to be effective in influencing the national level, well, what happens is that relationships are built, they cannot be forced. So even if the national level says, well, you need to build a relationship, it will not happen unless there is this dialogue, these spaces for building the relationship, this exercise. So local level, working with municipal government is extremely important for trying to tackle structural barriers and structural challenges.
Absolutely.
I'd like to add, I believe in and, not and or. And so I believe that's the fundamental, is to work at the local level and build capacity and build relationships and build success. But I also believe that there is a role for monitoring at a national level and international level, and that has to be connected somehow to it. And I see some other questions about financial aspects. We already know that inequity costs countries a lot of money, and yet there's no, the politics are still not great in terms of let's go and change and get rid of inequity because it's costing the country a lot of money. So we're forgetting the drivers in the opposite direction of why people want to keep people in poverty, why people want food insecurity, why people want to continue wars. And those drivers, I think we need to identify and do something about.
I wanted to add to the question around how do you actually make sure that community engagement is effective, especially during a conflict. I saw that question. And it's really important, and I acknowledge that, because the question was also going further to say, how do you ensure that you don't overburden communities? Like really acknowledging the suffering that is happening and the difficulties of organizing during a conflict. And in my experience, I've seen that community engagement is very difficult when you are already in a crisis, whether it's a conflict, whether it's a climate-related conflict, crisis, whether it's a pandemic. And so I think thinking about how you strengthen community systems ahead of time is one of the lessons I think we are taking even from the pandemic and from some of the climate-related crises that we are now seeing, extreme flooding and so on and so forth. That if we can actually think about community engagement models, community system strengthening, and really work around that. In Ukraine, one of the organizations that was leading in distributing medicines, food, oxygen, is a community-led organization that has been funded and supported by the Global Fund for a long time. It's the national network of people living with HIV, and it came in handy. But there was no way to build that infrastructure if we were starting during the crisis. So this is leveraging years of support, of building, of capacity, and so on and so forth. So I think that's one of the things I mentioned in my earlier remarks, community system strengthening and thinking about how do we do that ahead of time and how do we stabilize that. But I really don't know how you then do that in a conflict setting, but I wanted to offer my reflections about what are we learning, going forward. Yeah.
Thank you, Rosemary. I think the thing is to always be trying, as Seita-san also said, right? There's no, I think using the opportunities, the pandemic of HIV, which you mentioned, also began as a crisis and has been such a model for mobilization of communities and activation of community voice, leaving a legacy for subsequent reform and future pandemics. So I think the thing is to just get started and to make those connections and work on making them endure. So my thanks to the panelists. We're going to do one more thing now as a group, as a large group, not just us, but all of you. Sorry we couldn't answer all your questions. Thank you for asking so many. I hope you'll find these speakers and pose them at a later time. But now we're going to turn the house lights up, and I'm going to ask you all to stand, including the speakers. So we're all going to stand. And we can face any direction we want. So, well, probably any direction you want. Yes, we can stretch a little bit. Face whatever direction you want. I'm going to start here. Look around the room. Look around at the people here. Now, pick a person and meet their gaze. This is a bit of an awkward activity. So you're obviously smiling, right? But perhaps in addition to smiling, you'll nod your head. Perhaps you'll blink in acknowledgement. Perhaps you'll do what my girls do and stick your tongue out.
No, it's not polite.
It doesn't have to be polite. It can be friendly. We know that building peace takes a lot more than things like this, but doing these kinds of things, meeting someone's gaze, seeing and being seen, sharing a joyful smile, nodding your head in respect as they do here. Actually, they move their whole bodies here in respect. Blinking in acknowledgement and making silly expressions in innocent play. These connections matter. They are also part of peace, right? So please go. Some of these people you've locked eyes with, please go speak to them later. Please build these connections. Our agenda is huge, and these connections will matter. And I want you to see if you can talk about what your heart felt in this plenary, what your head thought about it, and what your gut wants to do. Maybe you want to have a snack right now, but other things your gut wants to do. Let's commit to that. The Peace Park in this city in Nagasaki has a quote from the Indian poet Rabindranath Tagore. It was gifted by the government of Bangladesh to this city. And it is one of his poems, and it says, "Still, O my bird, O bird of mine, do not fold your wings, do not close your eyes. Keep your eyes open, please communicate, please talk, and let's build justice, inclusion, and belonging in our work here and beyond." It's been an honor to moderate this session. I'd like to invite our chair back to deliver her concluding reflections and take us forward with the day.
We sit?
We can sit.
Very good.
Thank you everyone for taking this moment to connect. Indeed, this simple act of connection is a powerful reminder of what unites us all as humans. And these simple human connections are what we need if we really want to achieve equity and social justice in our world. If we open up more, if we understand, listen to each other, listen to people's hopes, challenges, aspiration, this is the only way we can build health systems where everyone feels they belong, where everyone feels respected, and where dignity is preserved. So I would like to thank our panelists for this thought-provoking session. Certainly there's many things to unpack, but I will keep my summary a bit brief. So certainly we've heard compelling insight from the panelists about the urgent need to build health systems that are inclusive, equitable, and just. Unfortunately, there is consensus, and we have heard that our health systems, as they currently are not built to foster equity and justice. So this is a starting point for us to acknowledge and realize. We've also heard that inclusion in healthcare is not just about access. It's about accessing care and receiving treatment in a way that is fair, just, and preserves your dignity. You have to be respected as well. And more importantly, we have been reminded of the deep-rooted social and political inequities that dictate what is meant by conflict and peace, and that also shape our health outcomes. This means that really, if we want to make changes, we cannot ignore the social and political inequities that persist. We've also heard from our panelists about some solutions, from systemic and structural changes, legislative changes, down to community, to advocacy. And in all that discussion, human and people should be at the center of any action we want to take. Our panelists also reflected on what the term conflict means. And it's interesting to see that it doesn't mean the same for everyone. For us in the Middle East, conflict is big, it's visible, it's the elephant in the room, it's bombs, it's bullets. For other panelists, conflict is more subtle. It doesn't make it less important. It's violence because they cannot have access to clean water. It's violence because of food insecurity. It's violence because of premature death due to being neglected, due to unequal opportunities in life. These are all different forms of conflict that we should keep in mind moving forward. Importantly, we must consider our roles and responsibilities as researchers, funders, advocates, community members. What can we do to improve the situation? So, as one of our panelists mentioned, our health system is designed for the privileged. So as we leave today's session, I just want to encourage you to consider your role within the health system. What would you do, each one of us in our capacity, to make things a bit better? How can we work to ensure that no one is excluded from care? And more importantly, what can we do? What role can we play? How can we contribute to making sure our health systems do not value more lives than others? Our role today here is not just to bear witnesses to the different stories of inequities that we have heard, but to act on them, to take a step moving forward. So I hope you take this as an inspiration and a commitment for you to do something the next time you witness injustice and exclusion. Because remember, silence is complicit and inaction is decision. Thank you all for this excellent session.
We have to do that now.
Really hit the heart.
Thank you.
Excellent, Racha. Really fantastic. Really well done. You were brilliant.
Thank you.
Thank you.